Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm the digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Well, we have a very exciting episode today all about the 2025 proposed rule for the quality payment program. So let's just get started. Are you ready, Dr. Mingle?
Roll 'em, Kyle.
Our first question for you today, Dr. Mingle, is what's proposed in the proposed rule for MIPS?
Great question, Kyle. That's certainly the foundation of the quality payment program. Well, first is proposed to keep the performance threshold at 75, at least through the 2025 performance year. I don't see any reason this wouldn't be desirable and don't see any reason why it won't be finalized. To keep the data completeness requirement at 75%, at least through the 2028 performance year. So they're looking a little ahead and proposing to keep it the same for a number of years now. Now, that can change in any annual rule cycle, proposed, finalized, and go into place. But I don't see any reason this wouldn't be desirable, or that Medicare would not finalize the rule or keep it at 75% as they promised through 2028. Now, there's the usual fiddling with the measure inventory on all of the performance categories. No changes are proposed to the promoting interoperability measure set this year, and they're confirming the previous intention to end automatic reweighting for clinical social workers. But they'll leave all the other special statuses, small practices, non-patient facing, untouched, presumably permanently. Quality measures, there's 9 new measures proposed, including 2 new outcome measures, proposing to remove 11 measures from the inventory, update 66 of the measures, and leaving us with a 2025 MIPS CQM measure inventory of 196 quality measures. Now, I'm not going to go into details of any of those. They can all be found in the appendix attached to the proposed rule. So if there are measures you're particularly attached to and don't want to see ended or changed, check out the measures you like in that appendix. Improvement activities, proposing to add 2, modify 2, and remove 8 for a total inventory for 2025 of 100 measures. Now, there's one very important change to improvement activities. They're proposing to eliminate the weighting of improvement activities. Previously, there were medium and high weight activities. They're proposing to remove that infrastructure completely and just count activities. So MIPS individuals and groups on a standard are required to report 2 activities for a full score in improvement activities. Small practices and other special statuses, 1 activity is required. MVPs, 1 activity is required. Also, no change to the expectation that practices in alternative payment models still get a practice improvement activity score specific to that APM. Currently, all APMs are still getting full credit for practice improvement. Cost measures, there are 6 new episode cost measures proposed, 5 new chronic condition measures proposed, 1 acute inpatient medical condition measure, and changes to 2 existing cost measures. Now, there's a very important change proposed in cost measures. They propose to change from the straight percentile ranking or decile ranking for scoring to a modified curve. They propose to take the median score from 5, where it now sits, up to 7.5, correlating, they think, with the performance threshold score of 75. So 7.5 out of 10 cost achievement points is what they propose for the median score, and then use standard deviations to spread out the scores from from 1 to 100 or 1 to 10. What this will do is pin the bottom, keep the bottom pinned at 1 or potentially 0, pin the top score at 10, and so the people scoring at those levels won't have a change in their score, but that median score get moved up to 7.5 from 5. Now they gave an example that says a practice where a slightly above average score would change the scoring from 2.3 in the current pattern to 7.7. So you can see this would raise that score dramatically. No one would actually have a decrease in scores from this change. So I don't see any reason not to support the change. I think it would be good for everyone and see more people able to meet the performance threshold and be in the incentive range. They're also suggesting another amendment to the topped-out measure treatment. That gets addressed almost every year. For measures judged to be important to specialties otherwise underserved by measures, they want to keep those topped-out measures and remove the 7-point cap, and then propose a flat benchmarking schedule from 1 to 10 points for those especially important topped-out measures. They'll abbreviate the top end of the scale, providing 10 points for anyone with a perfect 100% performance score. But skipping the scores in the 9s range entirely, with the next higher score to 10 being 8.9, which is a lot better than the current 7 points that a topped-out measure gets. A raw score of 84% would earn 1 achievement points, with everything below 84% coming out 0. So pretty devastating on the lower end of the scale, but that's the nature of a topped-out measure. They tend to cluster all at the top. I don't see any reason not to approve this. I don't see any reason why Medicare will not finalize this. Now, they're also proposing adjustments to the handling of multiple submissions. So there's two kinds of multiple submissions. First type is multiple submissions of the same type from the same entity, like Mingle Health submitting 2 different registry measure sets for a client, or practice themselves uploading with a practice administrator uploading 2 different sets of measures. Now, anytime the same entity submits the same measure type, they intend to go with the most recent, and that's what we've been experiencing as long as we've been in Medicare quality reporting. Submissions of different types or the same type from different entities, 2 different registries submitting competing or overlapping submissions, the most advantageous score will be used from those. Now, they're also proposing a reweighting option that's unusual for reweighting requests, in that it can be retroactive. It can be submitted later in the submission cycle for practices who don't submit data due to a third-party failure. So, and again, I don't see any reason why you wouldn't want that to be adopted, or why they won't adopt that into the final rules. I think that's everything fit to print about the MIPS proposals, Kyle.
So as I understand, Dr. Mingle, there are also proposed changes to the definition of a submission. Can you explain this?
Yes. They're not explicit as to why they're doing this, but it would appear that they're doing it to protect individuals and groups who've been granted a hardship exception. Now, if you're familiar with the terms of hardship exceptions, you can ask for one, they decide whether it's warranted, they grant it, but if you make a submission anyway, it just erases the hardship exception. Now, it appears that there's some clerical reasons why some submissions are made, empty submissions are made. They identify a tax ID number and or for a group, or a tax ID NPI for an individual, and that measure is empty. It can happen in improvement activities. It can happen in promoting interoperability. It can happen in quality. So they've had these empty submissions that they've received that have erased the hardship exceptions for people. Now they're proposing to put a little bit more definition as to what constitutes an exception, and those empty submissions won't count anymore. So quality must have at least one measure delineated with a numerator and a denominator. If it's an improvement activity, it must have at least one measure that has a yes attestation to be a real submission. And if it's promoting interoperability, all of the required measures with values have to be included. So this is an important change. I think it'll help those people with a hardship exception. I don't see any reason why you would object to it, or that Medicare won't finalize that proposal.
So, Dr. Mingle, what's newly proposed for MVPs, that is MIPS value pathways?
One, they're confirming the draft timeline, but still fairly unspecific about the eventual sunset of traditional MIPS and the implementation of full-time MVPs. Suggesting the switchover is going to be sometime around 2028 or 2029, proposed again, although saying or not necessarily saying that traditional MIPS will end in 2029. So just that it's still undefined, still way up in the air. There are 6 new MVPs proposed. They're proposing to combine the 2 neurological MVPs because of a change in measure availability, making it just one neurological MVP for a total of 21 MVPs available for the 2025 year. Now, Medicare is pleased that with this update, most specialties are going to be covered by a proposed set of MVPs. Now, there will be more to come because it's not all specialties yet. And there is an RFI requesting input into the details of MVP implementation and use and readiness. So look for that and make your comments if you have some opinions about that.
So, Dr. Mingle, what's newly proposed for Medicare Shared Savings Program Accountable Care Organizations? That's MSSP ACOs.
Thanks, Kyle. Good question. First, they're proposing an update to attribution eligibility. Not attribution itself, but what patients that are seen by ACO providers are eligible for attribution. This will change the denominator that would determine whether a provider is a qualified participant or a partially qualified participant. So they're proposing to expand the filter from at least one E&M code. So all patients who've had a visit where there's been an E&M code charged in the applicable year to any service code whatsoever. Now, attribution determination would still be unchanged. There's a prospective attribution potential. Then there's the high probability of primary care codes, particularly annual wellness checks. And then for anyone who doesn't place with one of those techniques, the preponderance of care or plurality of care, measure. So you'd still you could get some new patients attributed through this, but mostly it would change the denominator, not the numerator. So I'm not sure that this will be desirable. So if you don't want to see that change, make your comment. I think this is up in the air whether they'll accept it or not. So we'll carry on from there. Next is a continued refusal, important, to postpone sunset of the web interface. So that's still on target, that this 2024 performance year is the last year that the web interface is eligible as a collection technique to give your quality metrics to Medicare. They're proposing to expand the APP measure set to what they're calling the APP plus measure set. Now, I was expecting this to happen, but this is a little earlier than I expected to see it. So as of 2025, they'd like to add measures to that APP measure set. Now, they're proposing something that we expect to have some longevity. First, they want to align the APP measure set with what's called the Adult Universal Foundation measure set. 3 submittable measures and 2 administrative claims population health measures that Medicare calculates. One of those is not a universal foundation measure, although they don't propose to remove that. They're proposing to add the other 5 universal foundation measures to the list. For 2025, they're proposing to add breast cancer screening and colorectal cancer screening. That's measures 112 and 113 to the APP requirements. For 2026, they propose to layer in substance use disorder treatment, measure 305. And for 2028, skipping 2027, in 2028, adding screening for social drivers of health and adult immunization status, measures 487 and 493. They're also proposing to drop the MIPS CQM collection method from the APP starting in 2025. So as of 2025, only permit ECQMs or Medicare CQMs as submission methods or data collection methods. Now, their intention with Medicare CQMs is that they are still a temporary collection type, but no time frame is proposed for its sunset. And if they do finalize this change, I would expect that would keep that around a lot longer until ACOs are confident universally that they can switch to ECQMs. Now, I think there are a lot of good reasons not to do that, and a lot of good reasons why you might comment against it, and I'm certainly going to comment against it. Prominent amongst those disadvantages, I think it will significantly increase the cost of reporting. It'll hurt disproportionately low revenue ACOs. That paradoxically, Medicare is quite pleased that low revenue ACOs generally generate more shared savings than high revenue ACOs. It's likely to be an exclusionary factor to push many, particularly small practices, out of ACOs and accelerate the consolidation of health practices, a trend that has not been seen to be more likely to increase the value in care, but more likely to increase the cost of care. I plan to dig into this more specifically at a future episode, so keep watch for that. And whether you agree with me or not, I recommend that you post your comments about this to Medicare through the Federal Register. Now, next proposal for Medicare CQMs, they propose that benchmarks for the first 2 years, instead of being performance year benchmarks, that they use flat benchmarks. So a pre-published set of benchmarks, and the proposal is in the proposed rule that tells you what your score is going to be at any particular performance level. Until 2 years after their introduction, there's enough data to set historical benchmarks. They're proposing 2 incentives for the use of ECQMs. One is to continue the favorable quality standard. And that is an indefinite extension. So the language will continue it until they end it. I think the current favorable quality standard is set to end after this submission year, or this performance year, excuse me. It's for MSSPs who submit the APP as ECQMs. The proposed rule includes language that extends it indefinitely. You meet the quality standard, collecting all of your shared savings if you submit ECQMs. All measures are submitted meeting data completeness and case minimum criteria. One outcome measures scores at least 10 points, and one other outcome measure scores at least 40. They're also proposing to add a complex organization adjustment bonus. That's any APM that submits ECQMs. Add 1 measure achievement point for each ECQM submitted. So an interesting set. I don't see any drawback from accepting these, or any reason that Medicare wouldn't make them final. So certainly think about it yourself and submit your comments to Medicare on all of this.
So, Dr. Mingle, I also understand that Medicare is seeking input and feedback on several different issues. Can you tell us about those?
Medicare's including requests for information in the proposed rule is a habit that's longstanding, and it's a great opportunity. It's before they set any policies in. Well, it's never in concrete with Medicare. It's always changeable with the next rule cycle. But they're specifically looking for input about MVP adoption and subgroup participation. They're looking ahead to the sunset of traditional MIPS and the advent of a full-time MVPs, and they want to know how you feel it can be implemented. And they give a number of specific questions in this request. I think the best place to find it is in the fact sheet that comes out with the proposed rule, and you can find this on the QPP website. Look at the resource library. There's a regulatory section, a box section near the top of the page, and you can access the fact sheet. And this will outline all these RFIs. So one about the MVP adoption and subgroup participation, one about the public health and clinical data exchange objectives in promoting interoperability. I think they're a little frustrated with how little progress is being made on that, and they want to know your thoughts about how to make this more achievable. And also, they want to put more patient-reported outcome measures in the measure inventory. And they want to know your feeling about that and suggestions for how to make that work. They're also thinking about the CAPS survey, the Consumer Assessment of Healthcare Providers and Systems for MIPS. And they've done a recent study that shows adding a step to the survey increases participation. Specifically, currently, the survey starts with a mailed survey request. For those patients who don't respond to the mailed survey, it's followed up with a telephoned request. They're proposing to add a new first step before the mailed request goes out to offer a web access to the survey. And their preliminary study suggests there's a 13% increase in response rates in the current protocol. They're concerned that it could increase the cost of the survey and want your opinion about the feasibility of adding that web distribution. I think also anticipating that it may be difficult to get the email addresses necessary to distribute it and how you feel that might work. I think those are the major things. There may be some others, but these are the ones that you call out in the fact sheet.
So for our final question today, Dr. Mingle, let's go back to the subject of APP+. What can ACOs expect from Mingle Health for help with this proposed change?
Well, we have you covered for Medicare CQMs. For us, Medicare CQMs are business as usual. It's the techniques we've always used to do quality reporting, with the minor addition of this is a Medicare filter. This is a Medicare patient filter applicable to the denominator for every measure. So we will continue our full support of Medicare CQMs as long as it's an acceptable option for you to submit the APP. Now, we can and do use all electronic sources of data that ECQM providers can use. So we will continue to use those electronic sources as much as we can to make your Medicare CQM submissions. And we'll use that to help you identify the holes in your electronic data and fix it to make you able to use ECQMs. Now, we are renewing our own certification for ECQM submission, and we'll be ready when you are to switch over to ECQMs from that Medicare CQM platform. So we can make the switch with you to ECQMs whenever you're ready for the switch. Now, I'm not actually in favor of removing MIPS CQMs. I think they're superior in many ways to ECQMs. ECQMs, in my opinion, are a better measure of your technical capabilities. They're a better measure that your EHR is able to do the things Medicare thinks it should do. But I think MIPS CQMs are a far more accurate measure of quality that's accessible by means of cost and capabilities to all ACOs of all types and sizes, all practices of all types and sizes. And I think it'll be bad for the population, bad for the healthcare providers to lose that option. Now, they're not proposing to remove it from the MIPS system, at least not yet, or from the MVP system. But I don't think it's a good policy particularly for ACOs. I think it's harder for ACOs to do ECQMs, and it will be harder for ACOs for the foreseeable future than it is for solo doctors or MIPS groups. So keep an eye on our coming episodes. I plan to dig into more detail into this, coincident with my submitting comments to Medicare about my opinion on that.
Before we conclude, I want to remind everyone that we want to hear your thoughts and comments and questions on the proposed rule. So if you have a question or a comment, please send it to hello@minglehealth.com. You can also leave it in a comment here on YouTube or on LinkedIn. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. Thank you for all the great questions. And thanks all of you out there for continuing to submit your questions and requests for clarification. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience and opinions. Ask your questions. We can be smarter together.